From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to this JAMA Clinical Reviews podcast. I'm your host, Dr. Revital JAMA Fishbein Fellow and neurologist. Today I will be speaking with Dr. Ingo Mellinghoff. Dr. Ingo Mellinghoff is a neuro-oncologist at Memorial Sloan Kettering Cancer Center in New York City, where he is the chair of the Department of Neurology. As a clinician scientist, he has participated in and led numerous clinical trials. His research laboratory focuses on molecular and genetic changes in brain tumors and the development of new treatments for these tumors. We will be discussing the review article written by Dr. Mellinghoff and co-author Dr. Lauren Schaff on glioblastoma and other primary brain malignancies in adults, published in the February 21st, 2023 issue. Dr. Mellinghoff, thank you for joining us on the podcast today.
It's my pleasure to join. Thank you for having me.
In your review, you note that the annual incidence of primary malignant brain tumors is about 7 per 100,000 people per year, with nearly half of these from glioblastoma. Roughly speaking, how common are primary malignant brain tumors in comparison with metastatic brain tumors and benign tumors?
So there's approximately 85,000 individuals in the United States who are diagnosed with a primary brain tumor every year. And about 1/3 of those primary brain tumors are malignant. And within that group of malignant brain tumors, around 80 or 85% are gliomas. And those are the tumors which diffusely infiltrate the brain parenchyma in adults. And they are subdivided into many other subgroups, which we will talk about, I'm sure, a little bit later. The main cancer type that comes, I think, to everyone's mind is a glioblastoma. That is the most common malignant primary brain tumor in adults. And that is a tumor that increases after the age of 40 in incidence and peaks in adults around 75 to 85. And that is in contrast to lower grade diffuse gliomas, which usually afflict patients under the age of 50. And then there are less common malignant brain tumors. And in that group, there is primary CNS lymphoma. That is a rare variant of non-Hodgkin's lymphoma that only presents in the brain and does not occur outside of the brain. Occasionally, meningiomas that can turn more malignant, even though the vast majority of meningiomas in adults are not malignant, they are benign. And then the most sort of diverse and increasingly better understood subgroup of malignant brain tumors are ependymomas. These can arise in the supratentorial brain, also in the posterior fossa and spine, and they are more common actually in children. In the general medical practice, you will see many more patients with metastatic brain tumors that originate in other sites, particular, for example, lung cancer, and then metastasize to the brain. So these malignant metastatic brain tumors are the bulk of what you will encounter in a general practice.
Thank you so much for going through that. In follow-up, I wanted to get a sense if there's a useful way to conceptually organize these various types of primary malignant brain tumors. What's a good way to think about these? Should we think about them as age of onset, anatomical location, or is it really molecular classification?
Let me start with the gliomas. So the diffuse gliomas, as I mentioned earlier, really are the most common malignant primary brain tumors in adults. And for those types of tumors, we classify them now primarily based on their molecular features and age. For example, there is one genetic alteration. The name of the gene is isocitrate dehydrogenase, also abbreviated as IDH. And this status of that gene really stratifies all the adult diffuse gliomas into two groups: the tumors that have an IDH mutation and the tumors that do not have an IDH mutation. That is sort of the first dichotomy. within the adult diffuse gliomas. And within the tumors that do have an IDH mutation in adults, there is a second marker, and that is a co-deletion of 1p and 19q. So that's a chromosomal alteration that further divides them into tumors that do or do not have the second genetic alteration. So as a first approximation, you can think of the adult diffuse gliomas as three groups. One is the tumors that do not have an IDH mutation. We call them IDH wild-type gliomas. And then the other group is the tumors that have an IDH mutation and a 1p19q co-deletion. We call them oligodendrogliomas now. And the third group that have IDH mutation but do not have a 1p19q co-deletion, those are astrocytic tumors. So that is a very useful framework now for the classification of what used to be a very heterogeneous group of tumors. It has clear implications on prognosis and treatment. Another consideration, I think, for a general practitioner is the age of the patient. Just to back up, because it is such an important question, I would like to emphasize that these brain tumors are classified according to the WHO classification of tumors of the central nervous system. And that classification has been updated twice in the last 10 years, in 2016 and again in 2021. And the main change really has been the appreciation of the importance of molecular alterations in the classification of these tumors. So historically, the primary brain tumors were classified based on their histological appearance. Over the last 10 years, this framework has been supplemented and almost replaced by an increasing number of molecular alterations. This is what we now call an integrated reporting framework, where we have the first layer is the histological classification, and the second layer is the molecular classification. And together, you arrive at what is an integrated diagnosis that considers both the histological as well as the molecular properties of the tumor.
That was an excellent review, extremely helpful, and also interesting to learn the evolution of a classification over the past decade or so. We would expect brain tumors to manifest at some point, whether it's acutely or subacutely, with neurological symptoms related to their location in the brain, such as headaches, seizures, neurocognitive or behavioral symptoms, and focal deficits. Some symptoms are likely to come to medical attention more immediately, like a new onset seizure, but other symptoms may appear more commonplace initially. Can you give us a few examples of what you would consider common presentations and then maybe more challenging, nebulous symptoms that come to medical attention?
Absolutely. So headaches are common and found in about 50% of patients with newly diagnosed brain tumors. And almost everyone with a headache does not have a brain tumor. So the question always is, what type of headache should you worried about? What should you be worried about? And generally, headaches that are associated with sort of red flag symptoms, they include acute severe headaches, which really are different from any prior headache pattern, new headaches in older adults or children, headaches that are positional or worsen with exertion, and headaches associated, and that's probably the most distinctive feature with any new neurologic symptom. And when the pressure in the brain is increased, they can also be accompanied with nausea or vomiting and fatigue. And in extreme cases, when there is very high intracranial pressure, patients even can have episodic loss of consciousness, so-called plateau waves, and that might be mistaken for seizures. I have certainly witnessed those. A little bit harder to sort out are these focal neurologic deficits that relate to the location of the tumor. And then, of course, as you mentioned, seizures are common, like headaches, very common, up to 70%. in patients with lower grade gliomas. So it's a mixture, I would say, of common symptoms such as headaches and seizures, depending on the tumor type, and then, a long list of location related symptoms that tend to be a little more subtle and difficult to pinpoint and often missed and only really elicited during a detailed conversation in the practice, in the office. When you really probe for these symptoms, it becomes obvious often to the patient and their caregivers.
Yes, that is very challenging. So there is, of course, much to consider with regards to the diagnostic process. Once you suspect a tumor on brain imaging and get a tissue diagnosis, when do you need to do a systemic workup and what might that entail?
Generally speaking, the most common primary brain tumors, they do not need an extensive systemic workup. The exception to that are CNS lymphoma, where we do need a systemic workup to exclude the possibility that this is actually a lymphoma originating from a different site. For the most common and the most problematic brain tumor, it's really all about the brain MRI scan. And once that the brain MRI scan shows certain abnormalities and you need to establish a diagnosis, there is no other way to get to that point other than a biopsy of the tumor.
I see. Thank you for clarifying that. Now, your review nicely outlines both in the text and tables the various treatment regimens for the different brain tumors. Can you please bring us up to date on the current best practices in treatment, and if there's anything new in the pipeline, particularly for glioblastoma, since we know it has such a poor prognosis and short life expectancy?
Sure. So the first step in the treatment of these tumors is a good tumor surgery. That is very important. We call it, safe maximal resection, which means that we go out of our way to try to resect as much tumor as possible without compromising in any way, the neurological function. So the preservation of neurological function is a top priority before and during surgery because these tumors cannot be cured by surgery. For malignant gliomas, both glioblastoma and astrocytomas and oligodendrogliomas, so sort of the three main groups that I mentioned earlier, it is a combination of radiation and chemotherapy. For glioblastoma, which is the single most common malignant brain tumor in adults, the treatment is postoperative radiation. And the radiation is given in combination with an oral chemotherapy called temozolomide. It's an alkylating agent. There are a number of slight modifications to this. One has to do with the general performance status of the patient and the age of the patient. And then another consideration has to do with a marker. So there is a repair enzyme in the tumor cells that repair enzyme actually counteracts the activity of temozolomide. So we do not like this repair enzyme because it really gets in the way of temozolomide being an effective treatment. And so we measure whether or not this enzyme is active in these tumors. The name of the enzyme is MGMT. So it turns out that MGMT methylation status has become one of the most useful predictive markers in terms of the likelihood that standard therapy will be able to contain this disease. More recently, there has been the FDA approval of tumor treating fields. It's a low frequency electromagnetic field. So there's really an urgent need to develop new therapies for glioblastoma. Most patients with newly diagnosed glioblastoma, on average live less than 2 years. So that is really an unacceptable state of the field. And there are many, many attempts to improve upon that. And the types of therapies that are being investigated, they run the gamut from targeted therapies targeting specific genetic alterations in these tumors, such as V600E BRAF is one of the more promising targets, but unfortunately very rare in this tumor type. But there are many other potential opportunities for targeted therapies. There has also been a great interest in immune checkpoint inhibitors. with inhibitors, antibodies that target the PD-1, PD-L1 signaling axis. Those drugs have been very successfully used in many cancer types, including CNS metastasis for certain cancers, but they really, unfortunately, have not been shown to be helpful in glioblastoma so far. So there are negative phase 3 studies in newly diagnosed and recurrent GBM. There has been a substantial interest in more recent years in oncolytic viruses. So there's a series of different viruses that are modified, engineered to promote sort of inflammation and an influx of immune cells into the tumor, and perhaps also directly kill tumor cells through infection. It is too early to really comment whether they are effective.
It would be wonderful if something came through. It is hopefully promising. I also enjoyed the emphasis on the surgical preservation of neurological function, how important that is, and also how treatment is adjusted depending, on patient's age and functional status. Can you please discuss if there have been any changes in prognosis over the years in some of the primary brain malignancies?
Yeah, one of the more recent findings is a long-term follow-up of trials that were actually initiated 10 or 15 years ago. And two clinical trials kind of stand out, and one is for astrocytic tumors, are the long-term results of the Kettering study, which really have established the value of adding temozolomide to radiation for patients with, anaplastic astrocytomas. And that really is very important that these studies now have matured. We do have long-term follow-up, and we have good confidence that there's real value in adding chemotherapy to radiation for those patients. And that's really important when you deal with a rare cancer type and you feel like you're the only one with this disease, and there's hardly any studies that definitively shown benefits for any of the treatments you're getting. So that is really, for us, for neuro-oncologists, has been sort of a gratifying experience in the last year or two, is that some of these trials that were initiated a long time ago now have matured and show clearly for astrocytomas the benefit of temozolomide chemotherapy. And also, even more exciting is the sort of for oligodendroglial tumors. These are the tumors with IDH mutation and 1p19q deletion, that the treatment of these tumors, these are grade 2 anaplastic oligodendrogliomas, these trials were initiated 20 years ago and have now matured and have shown that really long-term survival with this treatment is possible, where many patients have lived 20 years or more. And I think that's an important message to remember, that, you can actually achieve long-term disease control with the available treatment, even in the appropriate subset of brain tumors. So what that means is we should always make an effort to really make an accurate diagnosis of the subtype of brain tumor you have, and then initiate the treatment that can result in really long-term overall survival. And that has been gratifying, I think, to see that in the last few years, both the accuracy of the molecular classification of the tumors and then the connection to a therapy that can have clear activity, even long-term activity.
That is very encouraging for neuro-oncologists and, of course, patients and their family members. Dr. Mellinghoff, thank you for all you do to advance the treatment of patients with these conditions. And thank you again for joining us today to discuss this important topic.
Thank you very much for having me.
And thank you to all our listeners for listening to this JAMA Clinical Reviews podcast. I want to remind the listeners that further details may be found in the review article written by Drs. Mellinghoff and Schaff on glioblastoma and other primary brain malignancies in adults, published in the February 21, 2023 issue of JAMA. A link to the paper can be found in the show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. This episode was produced by Daniel Morrow at the JAMA Network. The audio team also includes Mary Lynn Ferkaluk, Audrey Foreman, Lisa Harden, Hannah Park, Shelley Steffens, and Dr. Linda Brubaker, Senior Editor, Multimedia. Thanks for listening.